We have John Broyles, CEO of the Coalition to Transform Advanced Care, Gary Backer, Chief of Strategy, Policy, and Legal Affairs, Capital Caring Health, and Tori Fields, Chief Executive Officer of Votive Health. CTAC submitted the Advanced Care Model, ACM Service Delivery, and Advanced Alternative Payment Model in 2017. Please go ahead and remember to unmute yourself as you present.
Thank you. I'm going to do some framing at the outset and then turn it to my colleague, Gary Backer, who was part of the team from 2017 that submitted and spoke before the PTAC. CTAC is a large alliance of nearly 200 organizations. You may not know CTAC, but you likely know our members, AERP, American Heart Association, American Hospital, large systems and health plans. And our focus is on transforming the experience of the patient and family from the point of diagnosis through to the end of life. So we're here speaking on behalf of the patient and family. Next slide, please. So our story today begins, from 2017, where we were last before the PTAC, and two things happened after that. One is you asked a lot of great questions, tough questions that helped us refine our proposal. We worked with the American Academy of Hospice and Palliative Care directly with CMMI to advance the key elements of the proposal that we reviewed with you into new payment models and heavily informed the CMMI Primary Cares initiative. So number one, thank you for your feedback and know that you are having impact. The second thing is that we had a realization that as sophisticated as the model of care that we submitted was, it wasn't enough. And so next slide, please. Because to really reach those who are completely outside the system, we have to work not just through Medicare eligible providers, but really intentionally in partnership with the community. And that brings us to the story of Shirley Roberson. Shirley was a colleague of mine, a friend, in fact, and recently a board member of CTAC. She lived with advanced cancer for over a decade. And during that time, she really taught us that trust is key. The relationship with the patient is key to this entire discussion around total cost of care. And really, it was during many ups and downs, many challenges with social isolation, challenges with transportation, food, pain for her, that her cancer was causing, that her faith community really stepped up. And Shirley would often say to me, when you feel like giving up, it's the community that's going to keep you going. And that's always stuck with me. And now she thought of community as including her oncologist, who would not just help her with her pain, but also remember to give her a hug and check in and see how her art was doing. But it also included the Area Agency on Aging. It included her church, Hartford Memorial Baptist. And I think as we think about where to go next, where the greatest opportunity for innovation lies, we believe that it's in reaching those who are completely outside the system, those who have been underserved for too long, and those who need investment in trust and trusted relationships. So as we think about how to get there, we have to think seriously about investing in the organizations that folks like Shirley believed in, not just as a charity, not just as community benefit, but as true partners as we move this $4 trillion health system that we have towards more person-centered care. And I'm going to turn it to my colleague, Gary Backer, to talk about some of the practical elements behind our recommendations there.
Great. Thank you, John. So thank you again for having us. It's a pleasure to get to come before the panel again. As John mentioned, we got to do this a few years ago. There's a couple of important themes to pull through that came from the earlier discussion with the PTAC, and I had the pleasure following our PTAC presentation actually become the Chief Strategy Officer for CMMI and help oversee the architecting and development of a wide range of the models that are being used today. And I think there's two important themes that emerge kind of from the conversation we had with the PTAC earlier and part of our work today. So one is we're strong believers in the power of total cost of care for a lot of the conversations that have been conducted today, but it's also important to ask about total cost of care for who, and to think about the different subpopulations that are being served under any particular model to make sure that things, in a sense, don't get over average. So paying attention to important subpopulations, not necessarily carving them out, but being aware in model design that if you're taking care of a substantial portion of people that are of a particular subpopulation, it may be important to kind of make sure that the model parameters are flexible enough that it can accommodate those populations and make it feasible to successfully serve those people. Second point has to do with nested models. And I say this all the time. One of the things that I remember from the PTAC discussions before was the discussion around, does it make sense to have broader nested models or standalone models? And the idea is we talked about, at the time we were proposing a model to focus on the seriously ill, which really did inform a lot of CMMI's work. And one of the discussion points was, well, why would you want a standalone model to focus on the seriously ill if we already have many longitudinal total cost of care models where their incentives should already be in place to actually focus on the seriously ill people with advanced illness? And we thought, and we still think, that that's actually a very, very valid point, but there's also some issues where if you build it they won't necessarily come. And so one of the questions is, how do you really have the right balance between broader population-based models where you are creating the right incentives or even minimum requirements to be able to offer certain kinds of services, a minimum of services, for instance, that should be used to make sure that everyone with serious illness receives the right care? How do you do that in balancing between a nested design where you have that as part of a broader longitudinal model versus a standalone model? And our view is, in general, you should try to avoid, and I'll use the term disintermediating, those that would be taking total cost of care and total quality responsibility for a population, but at the same time, you want to make sure that there are, for those patients that are not going to be aligned to some kind of a longitudinal model, that there is, for instance, a standalone opportunity so they can receive services that are important to their care. And then another point that we've taken away is really systematically identifying and addressing and assessing populations' needs. And John made this point very well, the importance of actually focusing on those around people that are giving them the support. And so really honing in on caregivers who do amazing work, but recognizing that they suffer a great burden. And how can we in the different models actually, for instance, do a better job of supporting caregivers? And that leads to the final point, which is how do we do a better job of bridging the divide between healthcare and the community, the divide that John spoke about. And if you think about our models, most of them really have a sort of a medical provider construct to them. So very typical in a model, there'll be a participant provider and a preferred provider, but we don't really have formal room for the community in our models. And so beginning to think about how do we do that and how do we actually create new infrastructure on the ground. Sometimes we refer to it as a hub or a marketplace where we can, for instance, bring together healthcare organizations and community-based organizations and provide support for those community-based organizations, whether it's with contracting or data management and reporting. And then finally, the one hard issue we're going to have to address is ultimately how do we pay for these services? Because if we're talking about Medicare beneficiaries, Medicare has a big gap in terms of its coverage. And that's because it really doesn't pay for non-medical services. It doesn't really have a clear payment stream for services that meet people's social determinants of health. It doesn't have a payment stream that meets what in the Medicaid world we would call long-term services and supports, and it doesn't really have payments for long-term care. And so we really have to begin to figure out, given those deficits and those gaps, how do we, for instance, find ways to pay for services that would close the gaps that people have. And a lot of that, I think, begins with bridging the divide between the healthcare world and the community. So with that, I'm going to turn it back to the panel. Thank you very much for having us.